Good evening, everyone. This is the last installment of the breast pathology series. This is the third lecture. Today we'll be discussing morphology and clinical features of breast carcinoma. The most common location of breast carcinoma is the upper outer quadrant, representing 50% of the cases, followed by a central location, or as mentioned in some references as retroareolar location. 4% of the cases are bilateral. This is a schematic presentation representing rough percentage of involvement by carcinoma per quadrant. The classification of carcinoma depends largely on whether or not the neoplastic cells have penetrated the basement membrane. If you look at the picture, this is a picture of a normal mammary parenchyma. As we mentioned before, it's composed of two cell types, epithelial and myoepithelial. And these glands, are surrounded by a basement membrane-like material composed of type 4 collagen. If the neoplastic processes have invaded through this basement membrane, then this is called invasive carcinoma. If the neoplastic process is confined to the basement membrane, meaning the basement membrane is intact, then this is called carcinoma in situ. So basically we have two families of carcinoma, the non-invasive and the invasive ones. The non-invasive can be divided into ductal carcinoma in situ and lobular carcinoma in situ. The invasive family has many cancers, and this is just a limited list of those subtypes. The most common one is invasive ductal carcinoma of no special type, representing around 70 to 80% of the cases, followed by invasive lobular carcinoma, representing 10 to 15%. Other subtypes of invasive carcinoma include carcinoma with medullary features, mucinous carcinoma, tubular carcinoma, each one of those representing around 5%. There are many other rarer subtypes. You don't need to worry about these. Ductal carcinoma in situ, it has no invasion of the basement membrane. It varies in grade from low grade, meaning it is composed of small monotonous cells, to high grade, in which the cells are variable in size and shape and typically have fine chromatin and prominent nucleoli. DCIS can have central necrosis, also known as comedonecrosis, and the necrotic material can calcify. This is important because this is how most of the DCIS cases are being detected nowadays by mammographic detection of calcifications. DCIS is seen only in 5% of unscreened population and 30% of screened women. This is largely because DCIS does not form a mass, it forms calcifications. And calcifications can be detected only by mammography, not by self-examination. Estrogen receptors should be assessed in all cases of DCIS, and if positive, treatment with anti-estrogen should be prescribed. With treatment, the long-term survival is around 97%. With no treatment, however, 1/3 of these will transform into malignancy in the same breast that they arise from. This is a picture of a low-grade ductal carcinoma in situ. Note how the cells all look the same. They are small, monotonous, with dense chromatin. This is an example of a high-grade ductal carcinoma in situ. Notice the cells being large with fine chromatin. The nucleolus is very prominent. Notice also the comedonecrosis in the center of this malignant gland. This is another image of a high-grade ductal carcinoma in situ. Notice just beneath the black line we have the neoplastic cells. Immediately interior to that is the necrotic debris and then the calcification. These chunky purple material. These are the calcifications. This is a mammogram of a patient with DCIS. The red arrow points at calcifications. This is how they appear in mammography, which is basically an X-ray for the breast. A special type of DCIS is Paget disease of the nipple. Please do not confuse that with Paget disease of the bone or Paget disease of the vulva. When Paget disease of the nipple happens when the ductal carcinoma in situ cells extend into the lactiferous ducts and the skin. This is associated in all cases with underlying malignancy. 50% of the time this is carcinoma in situ, and 50% of the time it's invasive. But in all cases of Paget disease of the nipple, there are associated underlying malignancy, which is in sharp contrast with Paget disease of the vulva, as we will see later. Typically, patients present with crusting, itchy, and red scales on the nipple that looks like an eczema. This is an example of a Paget disease of the nipple. Notice the red scaly material on the nipple, and on the right hand side of the picture, notice the large cells with the red arrows. These are the ductal carcinoma in situ cells involving the skin. Lobular carcinoma in situ. It's typically an incidental finding on a breast biopsy performed for a different reason. They do not form masses, so they cannot be detected by physical examination. They rarely calcify, so they are rarely detected by mammography. Again, the most common presentation is incidental finding by a breast biopsy. These are formed by loosely cohesive cells. 1/3 of these will transform into an invasive malignancy affecting both breasts. DCIS increases the risk of malignancy in the same breast that harbors DCIS, while LCIS increases the risk for both breasts. So basically, LCIS is a marker for increased risk of invasive malignancy and also a precursor lesion to one. Treatment involves anti-estrogenic drugs, radiologic follow-up, and sometimes prophylactic bilateral mastectomy. This is an image of lobular carcinoma in situ. Notice that the overall architecture of the lobule is kind of maintained, unlike DCIS, which tends to destroy the overall architecture. The cells are small, monotonous, and poorly cohesive. Infiltrative ductal carcinoma or invasive ductal carcinoma is when the neoplastic cells invade and destroy the basement membrane. The most common subtype is invasive ductal carcinoma of no special type, representing 70 to 80% of the cases. It's typically associated with a desmoplastic reaction. What's a desmoplastic reaction? Well, it's when the body tries to contain the offending malignant cells by forming fibrosis and edema around the cells. So it's a combination of fibrosis and edema around the cells in an attempt from the body to contain the neoplastic process. 2/3 of invasive ductal carcinoma of no special type are positive for ER, and hence they respond to anti-estrogenic therapy. 20% are HER2 positive ER negative, and 15% are triple negative. They have variable morphology from well to moderately to poorly differentiated neoplasms. This is a macroscopic image of a breast carcinoma. The whole picture shows a section from a mastectomy specimen. The center of the specimen is white, fibrotic, and looks like a star. This is the tumor, surrounded by the yellow glistening fat, which is the normal parenchyma of the breast, especially in elderly women. This image shows the 3 different grades of the breast invasive ductal carcinoma. The left hand picture shows the low grade or the well-differentiated type, which is composed mostly of glands composed of small monotonous cells. The other extreme is the right-hand side image, which shows a poorly differentiated tumor because it does not form any glands. It's composed of sheets of cells, and these cells are large, pleomorphic, with high mitotic activity. The image in the middle is the moderately differentiated, which is somewhat between the well-differentiated and the poorly differentiated tumor. infiltrative lobular carcinoma, two-thirds of these cases have associated lobular carcinoma in situ. They do not form glands, they form single files because of the loss of ecadherin. Ecadherin is a protein that connects cells to each other, and the lobular tumors are typically negative for ecadherin, meaning they lose this uh, protein that sticks the cells together. That's why in LCIS, as you remember, we mentioned that these cells are poorly cohesive, and that's because of the lack of ecadherin. This tumor is unique in its pattern of metastasis, meaning it has propensity to go to CSF, serosal cavity, ovaries, and the bone marrow. Almost all of them are ER and PR positive, and rarely HER2 positive. This is an image of an invasive lobular carcinoma. Notice that the cells do not form glands like invasive ductal carcinoma does. These are the single files, meaning the cells are going into parallel rows of low-grade cells. Inflammatory carcinoma is not a histologic subtype of breast cancer. Rather, it's a clinical term to describe breast cancers that show manifestations on the skin with thickening of the skin, redness, and a skin appearance that looks like an orange peel. Histologically, in inflammatory carcinoma, the dermal lymphatic vessels are invaded by the tumor cells like seen here in the picture. And this is what causes the unique appearance of the breast skin involved by inflammatory carcinoma. Inflammatory carcinoma carries a very bad prognosis. The third histologic subtype of invasive carcinoma is invasive carcinoma with medullary features. Typically, this tumor is triple negative for ER, PR, and HER2. It is composed of sheets of large atypical cells with dense lymphoplasmacytic infiltrates. It is associated with BRCA1 gene mutations, and it has good response to chemotherapy. This is a representative histologic image of carcinoma with medullary features. The left side of the picture shows lymphoplasmacytic infiltration, and the right side shows a sheet of composed of large neoplastic cells. Again, this tumor responds very nicely to chemotherapy and has generally good prognosis. Mucinous carcinoma is another rare subtype of invasive carcinoma. It is typically positive for ER and negative for HER2. It is composed of pools of mucin and very few neoplastic cells. This is an example of mucinous carcinoma. Notice that mucin is this whirly bluish material, and the arrowheads point at the very few neoplastic cells seen in this picture. Tubular carcinoma classically affects elderly women. They're typically small, and usually they're ER, PR positive and negative for HER2, and they carry very good prognosis. This histologic image, we can see tubular carcinoma. It's composed of variably sized glands, coma-shaped, irregular shaped, surrounded by fibrosis. The second part of today's talk is the clinical features. And there are some differences between screened populations and unscreened populations. To be clear, screening means mammographic screening for women at the age of 40 or older. In unscreened populations, the typical presentation of breast cancer is palpable masses. And for the mass to be palpable, it has to attain 2 to 3 centimeters of size. In that case, almost all of these are invasive, and 50% of them will have lymph node metastases by the time of diagnosis. In contrast, in screened populations in which the majority of women 40 years of age or older undergo annual mammography, the majority of these tumors are discovered before symptoms, meaning before they become palpable masses. 20% of them are in situ carcinomas, and when they are invasive, they are typically small, 1 to 2 centimeters. And only 15% have lymph node metastasis by the time of diagnosis. This underscores the importance of screening at a large scale, because screening offers the possibility of detecting a tumor at an early stage, before it has reached regional lymph nodes, and definitely before it has arrived into distant organs, forming distant metastases. This early stage detection offers the patient a good chance for cure and less and less recurrences and more survival. There are three major factors that affect the outcome in breast cancer, namely biologic type, RNA expression profiling, and tumor stage. The biologic type deals with three factors: the histologic type, the grade, and the expression of ER, PR, and HER2. The histologic type, as we mentioned earlier, sometimes have good prognosis, like mucinous, medullary, and tubular carcinomas, while others have bad prognosis, such as high-grade ductal carcinoma of no special type and inflammatory carcinoma. The grade is a combination of the percentage of the tumor that is forming glands, meaning the more glands that are formed, the lower the grade. The more the tumor is composed of solid sheets rather than glands, it has a higher grade. Mitotic count, low mitotic count means low grade, high mitotic count means high grade, and cellular pleomorphism. The small monotonous cells have low grade, are low grade, and the large pleomorphic cells are high grade. The higher the grade, the worse the prognosis. Expression of ER, PR, HER2, and this is a mandatory assessment in each pathology report looking at breast carcinoma. The expression of ER and PR are associated with a response to anti-estrogen therapy and overall better prognosis. HER2 expression predicts response to anti-HER2, a medication called trastuzumab or Herceptin, with improved survival. The HER2 positive tumors are worse than the AR positive HER2 negative, but they are better than the triple negative. This graph looks at the hazard rate of breast cancers death over time. Notice that the AR negative tumors are significantly associated with a higher hazard rate of death compared to the AR positive tumors. And notice that this difference fades over time because even the AR positive responsive tumors, over time, they become more resistant to anti-estrogenic therapy. The second major factor is RNA expression profiling. This is a new method that looks at different gene expressions to further classify the tumor. You don't need to know the details about this. I just mentioned it here because I need you to know that the genetic expression and molecular assays are becoming mainstay of treatment and diagnosis in different types of tumors, not only breast cancer. Of the three factors affecting prognosis, stage will always be the most important prognostic factor. The staging system that we use is called the TNM. T stands for tumor, meaning tumor size, N nodes, lymph nodes, and M for distant mets. Mets is short for metastasis. T1, T2, and T3 look at the size of the tumor, while T4 is tumor of any size involving the skin or the chest wall. Using various combinations of the T and N and M, we have four major stages. Stage 1 is when we have a small tumor with no lymph node involvement and no distant metastasis. These tumors have a 10-year survival of 86%. Again, these tumors are likely to be detected by mammography, not by palpable examination. And that's why they have, because they're small, and they have a very good prognostic outcome. Stage 2 are larger tumors without lymph nodes or distant mets, or small tumors with positive lymph nodes, again with no metastasis. They have a slightly less 10-year survival of 71%. Stage 3 is when you have large tumors with lymph nodes involvement or tumor with any size that affects the skin and the chest wall, meaning they are T4. Again, no distant mets in either of these cases. The 10-year survival is 54%. Stage 4 is any tumor with any lymph node status but with distant metastasis, and the 10-year survival is only 11%. I would like to thank all of you for listening. This was the last lecture for the breast series. For further reading, Robin's Basic Pathology 10th edition is your reference to go. Please stay safe. Thank you and talk to you soon.